Welcome back. In Part A, we built the integrated clinical framework: history, examination, and laboratory findings. Now, in Part B, we apply that framework systematically, going through each category of jaundice: pre-hepatic, hepatic, and post-hepatic, and seeing what imaging adds to this picture. The philosophy remains the same: imaging confirms and localizes; history and lab tells us why; imaging tells us where and what. Ultrasound is always the first line. It answers the fundamental question: are the ducts dilated or not? That single answer immediately separates post-hepatic from pre-hepatic and hepatic. Then CT, MRCP, and MRI add the detail needed for definitive diagnosis and surgical planning. Pre-hepatic jaundice: excess bilirubin production from red blood cell destruction. The hallmark imaging finding is splenomegaly. The liver may be normal or mildly enlarged, and crucially, the bile ducts are normal, non-obstructive. The normal duct finding immediately separates pre-hepatic from post-hepatic. The hemolytic causes: genetic and acquired. Genetic causes include thalassaemia, sickle cell disease, hereditary spherocytosis, and 6-GPD deficiency. Acquired causes include malaria, drug-induced hemolysis, transfusion reactions, and autoimmune hemolytic anemia. Thalassaemia: the bones tell the story. Hair on end skull from expanded marrow spaces, paravertebral masses on CT. These are extramedullary haematopoiesis, not tumors. Massive splenomegaly: MRI T2 star shows signal loss in liver and heart from iron overload in transfusion-dependent patients. For details, see Short 23. Sickle cell disease: pathognomonic finding is fish mouth or head-shaped vertebra on X-ray. AVN of the femoral head: MRI shows subchondral T1 signal loss. End-stage disease: autosplenectomy, small fibrotic spleen on imaging. Dactylitis in children. For details, see Short 25. Malaria: unique because it causes double trouble: pre-hepatic hemolysis and hepatic involvement simultaneously. Massive splenomegaly, hepatomegaly, splenic infarcts, normal bile ducts. Blackwater fever is the most severe form. Massive intravascular hemolysis causing dark urine and acute kidney injury. For details, see Short 22. Genetic causes: Gilbert syndrome is common, affecting 3 to 10% of the population. Normal imaging completely benign. Reassure Crigler-Najjar type 1 is severe. Normal liver imaging, needs liver transplant. Dubin-Johnson has the characteristic dark pigmented liver on imaging. Rota syndrome, normal imaging, benign. For details, see Short 26. Pre-hepatic imaging summary: always assess splenomegaly and grade it. Check liver size and nicotexture. Look for pigment gallstones in young patients. Confirm normal bile ducts and order bone X-ray or MRI if clinically indicated. Normal bile duct plus splenomegaly plus jaundice equals pre-hepatic until proven otherwise. Hepatic jaundice: the liver cells themselves are damaged. Conjugation is impaired. We get a mixed bilirubin pattern. Both unconjugated and conjugated rise. Bile ducts may be normal or minimally dilated. Viral hepatitis: most common hepatic cause worldwide. Acute hepatitis on ultrasound shows hepatomegaly with a classic starry sky appearance, decreased liver echogenicity with bright periportal tracking. Gallbladder wall is diffusely thickened. Remember, not normal. Splenomegaly, normal bile ducts, Critical pearl: radiology cannot differentiate hepatitis types. All look identical. Serology is essential. For details, see Short 29. Cirrhosis: end-stage liver disease. The most important ultrasound sign: nodular liver surface, caudate lobe hypertrophy, right lobe atrophy, coarse echo texture, portal hypertension signs. What are they? Portal vein greater than 13 millimeter, splenomegaly, ascites, varices, Doppler showing hepatofugal flow away from liver, means very advanced disease. All cirrhotic patients need ultrasound every 6 months for HCC surveillance. Arterial enhancements with washout on portal face is a classic Lyrad's pattern. For details, see Short 28. Next, fatty liver disease. Bright liver on ultrasound, graded 1 to 3. CT shows liver less dense than spleen, less than 40 Hounsfield units. MRI PDFF is most accurate for fat quantification. Elastography for non-invasive fibrosis staging. For details, see Short 31. Infective causes: amoebic abscess shows solitary right lobe hypoechoic lesion with peripheral enhancement on CT. Hepatic TB: miliary pattern throughout liver and spleen and necrotic lymphadenopathy at the porta hepatis. Pathognomonic for tuberculosis. Calcification in healed TB. For details, see Shorts 33 and 34. Hydatid disease. Daughter cysts are pathognomonic. No other diagnosis gives this finding. For details, see Short 30. Liver flukes: three distinct patterns. Fasciola gives the tunnel sign on CT. Tortuous tracts from the migrating fluke. Clonorchix gives peripheral intrahepatic duct dilatation without central obstruction with significant cholangiocarcinoma risk. Schistosomiasis gives periportal pipestem fibrosis pathognomonic with dominant portal hypertension. Details given in Short 32. Autoimmune and metabolic causes: autoimmune hepatitis and primary biliary cirrhosis often show completely normal imaging early. Serology confirms anti-SMA, ANA, elevated IgG for AIH, AMA for PBC. Wilson's disease MRI brain shows the panda phase sign in the midbrain. Basal ganglia T2 changes. Low ceruloplasmin confirms hemochromatosis, hyperdense liver on CT, dramatic T2 star signal loss on MRI. For details, see Shorts 35, 36, and 48. Bucchiari syndrome: hepatic vein thrombosis, absent hepatic vein flow on Doppler, caudate lobe hypertrophy, because it drains directly into IVC. Flip-flop enhancement on CT is pathognomonic. Spiderweb collaterals and chronic disease. India-specific pearl IVC membrane obstruction is common and treatable with balloon angioplasty. For details, see Short 37. Pre-hepatic jaundice. Obstruction to bile flow. The key imaging finding: dilated bile ducts. As radiologists, we answer three questions: is there obstruction, at what level, and what is the cause? The master obstruction algorithm: 3 levels, 3 stories. Hilar block: only intrahepatic ducts dilate, gallbladder is collapsed and empty. Think Clark-skin metastasis or Milsey syndrome. Mid-level: both intrahepatic and extrahepatic ducts dilate, gallbladder distends if cystic duct is patent. Think stones or strictures. Ampullary block: both ducts dilate, gallbladder dramatically distended, Purvasey's sign. Think pancreatic carcinoma or ampullary carcinoma. And remember, fasting state is mandatory for gallbladder. Assessment: a fed patient with a contracted gallbladder gives you a false picture. For details, see Short 11. Choledocholithiasis: echogenic focus with acoustic shadow on ultrasound, dilated ducts upstream. Always confirm with acoustic shadow or twinkle artifact on Doppler. Don't call a stone without shadowing. That's the pseudo-calculus sign trap. MRCP is gold standard for confirmation. For detail, see Short 14. Britzy syndrome. Stone in cystic duct compressing the common hepatic duct. Trap. CBD is normal below the cystic duct insertion. ERCP may miss it completely. MRCP is essential to map the anatomy before surgery. Clutkin tumor at the hepatic duct confluence. Dilated intrahepatic duct, collapsed CBD and gallbladder. Bismuth-Corlett classification determines resectability. For detail, see shots 12 and 13. Double duct sign. Dilated CBD and dilated pancreatic duct simultaneously. 70% malignant. In elderly patients, the malignancy until proven otherwise. Think pancreatic head carcinoma, ampullary carcinoma, or IPMN. For details, see Short 9. Pancreatitis. Bidirectional relationship with jaundice. Stone causes pancreatitis. Pancreatitis compresses CBD. Acute pancreatitis on CT, you get edema, fat standing, peripancreatic collections. Necrotizing pancreatitis, non-enhancing pancreatic tissue. Gas means infected necrosis. So it's a surgical emergency. Chronic pancreatitis, you get calcifications, bead on string appearance of the pancreatic duct. CT is the gold standard. For detail, see Short 18. Imaging modalities. MRCP is the diagnostic gold standard for biliary imaging. Non-invasive, no contrast, no radiation. Replaces diagnostic ERCP completely. ERCP is now primarily therapeutic. Stone extraction, stenting, drainage, and tissue sampling. PTC and PTBD when ERCP fails or anatomy is altered. For details, see Short 19, 20, and 21. Polydocal cyst. Todani classification type 1 to 5 can be diagnosed prenatally on ultrasound at 18 to 20 weeks. MRCP is gold standard for classification and surgical planning. 20 to 30% lifetime cholangiocarcinoma risk if untreated. Complete surgical excision mandatory. Biliary ascariasis. Linear echogenic structure moving in the bile duct on real-time ultrasound. That movement is pathognomonic. Ultrasound is diagnostic. No other imaging is needed. For details, see shots 45 and 17. Post-hepatic imaging workflow. Ultrasound first to confirm dilatation assessment of gallbladder behavior. Fasting state mandatory. Determine the level of obstruction. Then MRCP to map biliary anatomy and plan intervention. CT for staging malignancy and assessing vascular involvement and resectability. Then ERCP or PTC for therapeutic intervention. The age-specific approach, because the differential diagnosis of jaundice shifts dramatically with age. Neonates. First question, is it physiological or pathological? Physiological jaundice appears day 2 to 3, peaks day 4 to 5, resolves by day 14. No imaging needed. Pathological red flags. Jaundice within the first 24 hours is always an emergency. Think hemolysis. Prolonged jaundice beyond 14 days in a term baby with conjugated hyperbilirubinemia means urgent ultrasound. Is it biliary atresia? The 60-day window for Kasai photoenterostomy is the critical deadline. Miss it and irreversible cirrhosis follows. Radiologist diagnosis here is literally life-changing. For details, see shots 39 to 42. Pediatric age groups. Hepatitis A is the most common acute cause. Starry sky appearance and GB wall thickening on ultrasound. Self-limiting, vaccinate contacts Wilson's disease, age 5 to 34 years, neuropsychiatric symptoms plus jaundice. MRI brain shows panda face sign. Low ceruloplasmin confirms. Autoimmune hepatitis, high IgG with hepatitis pattern, often normal imaging early. Liver biopsy confirms. For details, see shots 46 to 49. Then adults. Viral hepatitis B and C, cirrhosis, NAFLD, cholelithiasis, and drug-induced liver injury are the common causes. The integrated approach from Part A guides the workup systematically. Elderly, malignancy first. Always, painless jaundice weight loss in elderly patient means malignancy until proven otherwise. Pancreatic head carcinoma, Klatskin tumor, gallbladder carcinoma, especially high incidence in North and Central India in women. Ampullary carcinoma, metastatic disease. Urgent imaging is mandatory. Then consider cholelithiasis and drug-induced jaundice from polypharmacy. Imaging algorithm. Simple and systematic. Step 1. Ultrasound always first. Are the ducts dilated? Yes means post-hepatic. Proceed to determine the level. MRCP for biliary anatomy, CT for staging, ERCP or PTC for therapeutic intervention. No dilatation means pre-hepatic or hepatic. Proceed accordingly. Pre-hepatic workup. Assess splenomegaly. Confirm normal ducts. Proceed with hemolysis workup. Bone X-ray if clinically indicated. MRI T2 star for iron overload in transfusion-dependent patients. Hepatic workup. Assess liver echo texture. Look for portal hypertension signs. Identify disease-specific patterns like starry sky for hepatitis, pipe stem fibrosis for schistosomiasis, daughter-cyst for hydatid, then serology and biopsy as indicated. The modality guide: ultrasound for first-line assessment, CT for malignancy staging and vascular involvement, MRCP as gold standard for biliary anatomy, MRI for iron and copper quantification and liver parenchyma assessment, ERCP and PTC for therapeutic intervention only. Understand, jaundice is a symptom, not a diagnosis, and approaching it correctly requires integration. History for classification, examination for confirmation, laboratory findings for direction, and imaging for localization and characterization. Together, they give you the diagnosis. The radiologist's role is central, not peripheral. We answer the three fundamental questions: pre-hepatic, hepatic, or post-hepatic. We guide management: medical, endoscopic, or surgical. And in many cases, we actively treat percutaneous drainage, PTBD, and interventional procedures. But we cannot work in isolation. We need history, the examination, and the laboratory finding to complete the picture. The radiologist who touches the patient, reads the clinical notes, and integrates all available information, that radiologist gives the most valuable report. Thank you for watching. Part A covered the integrated clinical approach, history, examination, and laboratory differentiation. Part B has taken you through every category of jaundice with imaging correlation. Together, they form the complete framework. We have 32 shots covering every individual case in detail. Links are in the description. Subscribe to Punky's Medical Corner for more integrated radiology teaching. Teaching is learning. As you teach, so you learn. And I hope this series has helped you think about jaundice differently, not just as an imaging problem, but as a complete clinical challenge that we all solve together. Thank you for watching once again.